One.
So Dr. Williams, today is one of our webinars that we are releasing actually for the Martin Luther King holiday. And to our audience, we have Dr. Mel Williams, who will introduce himself, and we can take it from there. Dr. Williams, tell us a little about yourself.
Okay, hi. Dr. Mel Williams here, graduated from med school in 1974. And ironically, this would have been the, well, that's undergrad, but anyway, it's about 45 and change, et cetera, et cetera. I'm from a city called Yonkers, New York, right outside New York City, or the Bronx per se. And what got me into medicine, well, with certainty, I had an aunt who had gone to Howard University College of Medicine. She graduated in 1949. Very bright woman, very independent at that time, of course, in the 50s. I won't tell you some stories, but anyway. So she was a big influence. I had I left the New York area, Westchester County, and came down to Howard undergraduate school. And I applied to several medical schools, but I decided to stay in Washington and matriculated, as I mentioned, in 1974. Back to my aunt, she finished in 49. She, upon graduation, she went up to, did a residency in Peds, I think it was Jefferson or Hahnemann up in Pennsylvania, Philly. And she opened a practice. And I remember her telling me, she says, I'm going to close my office after 2 or 3 years because, you know, I love the children, the babies, but I'm having some issues with the mothers. So she left practice and went to New York City and got an MPH. And she worked with the John Lindsay administration. So she was quite influential. That was probably one of the reasons that I matriculated into the field. So I entered the College of Medicine in would have been September of 1970. And upon graduation, wasn't sure where I wanted to go. I was about 2 minutes from Los Angeles or San Francisco, but I decided at the last minute to stay at Freedman's Hospital, which was the predecessor of Howard University. Freedman's Hospital, if you may be aware, it was established by the Freedmen's Bureau, ex-Civil War soldiers and slaves back in the day. So it was Howard University Hospital's predecessor. So in I think it was January 75, that's when the transfer occurred. One of my former deans, he was a brigadier general in the National Guard. And basically he facilitated the transfer from Freedman's to Howard University Hospital. And I remember at the time, I think I was in the intensive care unit. I had 4 patients, small unit. And we had to bag the patients in the old ambu bag to the jeeps, military jeeps, and then transfer them, you know, about maybe a quarter of a mile, less than that, to the new Howard Hospital. But I remember that day. So I stayed at Howard and did medicine, internal medicine. We had some iconic professors at that time. Lester Henry, John Townsend, just 2 of them. I'm talking about the field of internal medicine. And my career, if you may, took an uncertain course at that time. When I finished my residency, I wasn't sure what I was going to do. I was going into practice, I was doing this, that, and the other, but I had a classmate who was in the public health service. And I used to go and visit him and about 3 or 4 doctors, outpatient ambulatory care. And they were happy and chirpy and cheerful. And of course, for the last those 3 prior years, I was working what we call in medicine, the salt mines, internal medicine. Tired, on call, so mostly every 4th, sometimes every 3rd. And he said, why don't you do this for 2 years? So what I did, I joined the public health service with the intent of staying for about 2 years. And that turned into 26. I had different positions while I was in what we call the Commission Corps. My first site was downtown, the Switzer Building, which is still there. Old HEW, now it's HHS. Big, huge clinic where we saw all active duty members and their dependents from all the services. Did that for 2 years and then went to St. Elizabeth's Hospital and stayed there for about 4 years. And I believe it was President Reagan at the time. I was with an inpatient program dealing with substance dependence. It was long-term. Very efficacy was quite good, but it was a very good program. But because of the budget at the time, that program was contracted out. So my next assignment was with the United States Coast Guard. Fortunately, I stayed in the Washington area and was the branch chief of the senior medical officers at the United States Coast Guard headquarters clinic at the time. It subsequently moved. It used to be opposite the HUD building down Southwest. So I was there for about 6 years. And then I came back to St. Elizabeth's Hospital and did ambulatory medicine again. I ran an outpatient clinic. I'm not a psychiatrist, but of course, dealing with patients with, some were triply diagnosed, a lot of manic depressive illness, a lot of schizophrenia, et cetera, et cetera. So I had to deal with the diabetes, the hypertension, HIV, hepatitis, you name it. So until 2003, at which time I retired from the Corps. I spent 1 year at Walter Reed, the old Walter Reed Army Medical Center that was on Georgia Avenue, with an IRB, Investigation Review Board. There was a colonel that was deployed to the First Gulf Initiative, and they needed a physician. So to look at protocols and reviews, et cetera, et cetera. So I was there for about a year, quite interesting, from the research side. And after that little tenure at Reed, I had a son who was at Morehouse College, and I had some rental property, and I just said, I had to evict the gentleman. So in other words, the wing wasn't working too well, so I had to go back to work. So I came and basically ultimately with the Public Health Service again in Rockville, the old Rockville headquarters clinic, or I should headquarters building at Fisher's Lane. Subsequently, that building has been renovated, but we've moved. I'm still with Medical Affairs. We've moved about 3 times. Currently, I'm in Rockville, Maryland, with the Medical Affairs branch with the United States Public Health Service. And basically, that's what I'm doing medically now. Fortunately, I'm able to telework because most of our files have been basically digitalized on the computers. So all day long, I'm looking at physicals, histories. My colleague and I were responsible for deployment around the nation. We have a few commissioned officers around the world, but now with COVID, of course, they're deployed, Indian Health Service, Bureau of Prisons, et cetera, et cetera. And we review that, we qualify them for fitness and look at any medical improprieties that may exist. I don't necessarily deal with the board proceedings now, but by proxy, we communicate with the physicians who sit on the boards for disability purposes, or et cetera, et cetera. So that's basically what I'm doing at this juncture. Of course, you mentioned I'm the president of MedChi. It's been my tenure should have been up, but because of the COVID, because we haven't been meeting person to person, we decide to fast forward here to keep the slate as it is, if you may. So this is probably my last year being president. A little bit about MedChi. I should let you ask some questions, but I'll just say, you might want to ask a few about MedChi, but I'll just say this. This coming March, it was founded March the 21st in 1884. It's the oldest, if you may, preeminently African-American medical society in the world. We're actually 11 years older than the National Medical Association. We were founded in March 21st, it was 1884, which this coming March will be 137 years.
Yes.
So a lot of history there. I can go on and on. Some of our notable former presidents, and I think Robert Hay was aware of Montague Cobb. He was one of my professors at the time, but he was former president of the National Medical Association, former president of MedChi. He was the first African-American in the United States to hold a degree in physical anthropology. Of course, he was an anatomist. He was professor of anatomy at Howard University. And quite brilliant gentleman, Montague Cobb, and he was really responsible, probably as we know it, for Medicare as we know it. It was in 1964 when the Congress voted to establish Medicare. I believe, I hate to be political, but there were no Republican votes at the time. But it was Montague Cobb, Dr. Montague Cobb, that kind of influenced President Johnson, that committee, that Medicaid should be launched, among others. But he was very instrumental in the launching of Medicare back then. And there's another little history that I should say this because it's history. One of the reasons MedChi was founded was because of the resistance. As you may know, African Americans back in the late 1800s and thereabout, we could not obtain hospital privileges. We couldn't join any societies. And it was our MSDC at the time that basically kept us out the door. Subsequently then, of course, that has changed. It was, I believe, probably in 1962 thereabout, a lot of little things have happened. And then basically, I do know, Robert probably knows the exact date. I can't give it to you, but must have been the 80s or 90s. There was an official, if you may, apology from MSDC about the history, because unless you were a local member society, you couldn't join the AMA, and you couldn't get your hospital privileges. So there's a long history with that. I won't dwell upon that, but Dr. Cobb did write a book on that subject. He said basically it took 72 years for African Americans to get privileges from 1870 to 1952, somewhere thereabout. But he was an icon, quite instrumental in the history of this organization. And basically the goal is, as we see with MSDC, is trying to, capture younger folks, younger physicians to carry this torch, to keep pushing it. So that's one of my goals, but ongoing. And I won't say any more at this junction until you ask me a few questions.
Well, you answered some of my preempt questions, and I did study up on the history of MedChi and its former name of the National Medical Society and why it was formed. So thank you for that little journey through history, and we'll return back to that. But I wanted to know, what types of struggles did you face in the pursuit of medicine?
Yeah, well, fortunately, I think going to undergraduate school at Howard was a unique. Prior to that, when I was in Yonkers, New York, I'll say this, from first grade to 12th grade, I was the only African-American in my class.
In Yonkers, New York?
This is in Yonkers. The first school was a parochial school. And there were some issues. I think I went to public school for a year, but there was an issue that happened, and my father said, okay, enough of this. I'm going to put you in Catholic school. He was always a stickler about education. He knew that the parochial schools, in this school, all nuns, no lay teachers. So he sent me to Holy Trinity School, which was in Yonkers, that for 8 years. And I think back then, I look at my achievement, if you may, I was probably a straight A student. I think I was class president in 8th grade. And then I wanted to get, I didn't want to go to Catholic high school because in proximity, there was a public school, and they would always kid around with the Catholic school kids and say, yeah, if you go to a dance, and the nuns will come around and tell you, spread apart, make room for the Holy Ghost, So I remember those conversations with the kids, but fast forward here, I went to public school for 1 year. It was a junior high, and then I went to high school called Rosewood High School in Yonkers, New York, when I graduated. And it was a basically recruiter that happened to come to that school one day that got me interested also at Howard at the time. This would have been in 1966. So as I mentioned, I went to undergrad at Howard, matriculated to the College of Medicine, et cetera, et cetera. But to answer your direct question, for the most part, no direct assaults, if you may, coming through. And I think a lot because of environmental, the folks who were around me. I look back growing up in Yonkers sometimes. New York, of course, and I believe Yonkers, it was one of the former, well, he's still president. It's a lawsuit, I think it was by the Nixon administration against the Trump empire, but his father guess the son, in the real estate business. And there was a suit that lingered on for about 25 years. And finally they settled it. But the discrimination about, rental. So I say New York, in a sense, ethnically was somewhat segregated in that sense. It wasn't brashly segregated, but it was almost like, for instance, went to school with Italian kids and Jewish kids, Irish kids, and it was, people for the most part respected. Once in a while, you'd hear catcalls coming around. People would use, negative words and scream out the window, et cetera, et cetera. But for the most part, my experience in Yonkers was pretty good. I mean, there are little snippets of this and that, but nothing brash. My wife's from Alabama, and of course, she could tell you a different litany of things because she grew up there, where, of course, you had Jim Crow was hard, heavy. She had to take her grandmother upstairs to get in the office, so you had to go to the movie theaters upstairs, but drink separate water fountains. So the North versus the South, there were some slight differences, I'll say about that. But wholesalely, for me, because of that environment, there was not significant impedance on my progress. I'll just say that.
Okay. Well, tell me, how have things changed or improved for African American physicians during your career?
As I mentioned, I came in the public health service. I don't think I gave you the year. That was 1977. I think the Corps, I'm gonna use that word, the Corps, the Commission. As you may know, there's 7 uniformed services, I'll just tell. Army, Navy, Marines, Air Force, Coast Guard, and NOAA, known as the National Oceanic and Atmospheric Administration. We're uniformed services. Theoretically, we don't carry guns. That's a distinction between the armed services and uniformed services. Now, when I came in the Corps, I'd say the number of African Americans in the Corps was about maybe 2%. Of course, that number, now we're talking from 1977 to 2021. I would say that number, and this is almost a guesstimate, because it's probably at least 35 to 40%, even if not higher. So there have been a lot of changes. There's no question about that. And even with that, there again, I didn't do my postgraduate training at a majority, I use the word majority, institution, where I know, there have been issues in the past. Even I remember a colleague of mine, I think he finished med school ahead of me. He went out to Harbor General Hospital, Los Angeles. And I remember he telling me, we were talking one day, and, here's a man coming in the emergency room, somewhat rebel, if you may, and, expounding acronyms and negativity and N-words, et cetera, et cetera. And I think he told me he got so upset that he almost told the man, I'm not treating you. But, Hippocratic oath, he did. But we didn't have to deal with that as much. St. Elizabeth's, I was there for a while. And the second tour there, when I was inpatient, the medical officers had to rotate into the on-call schedules with the psychiatrists. Now, as you know, St. Elizabeth's, there's a huge amount of history there in a long time. St. Elizabeth used to have about 8,000 patients. It was like a city, through the years. But anyway, so he had vestiges of yesterday there as well. A lot of times doing physicals, et cetera, I'd go to other buildings. And occasionally you'd hear other instances of negativity and racial epithets. These are from the older Caucasians that might be prancing. They were schizophrenic and they had some issues, but you'd see that. And that was probably, my encounter, but I understood that. These are people with Axis 1 diagnoses, and they had, a lot of racial undertow at times, but they were in a mental asylum. So, but for the most part, and to answer your question, how it's changed, I think it has, but there again, that is predicated on, I would imagine, where you are, very, I remember you talking about race, my summertime, I think it was my junior year when I was an undergrad, I'd go back to New York and work. And I had this job, I was working on construction with the electricians. And this job was out in Pelham. Pelham, you might have heard of the movie, Taking the Pelham 1, 2, 3. Anyway, Pelham is kind of like the East Bronx. But I worked with 2 gentlemen who lived way out in Long Island. And they remind me, for you guys are fairly young, but there was a movie back in the 70s called Joe. And I remember these guys were smashing Volkswagens with sledgehammers, and they were saying, America, love it or leave it. But that was the cadence at the time I was working with these gentlemen. I remember one guy asked me, he says, well, what are you studying? And I said, well, I want to be a doctor. And it was almost like he was doubting Thomas. Well, you can't do that. You have to be smart. But I understood that. So, but by and large, that was there. But I think basically now, and we would probably have to talk to some of the folks who are doing postgraduate training in other facilities, but to see. But I think I would have to say that there have been immense changes. Oh, I remember when I came to Howard, Georgetown's freshman class, I think there were 2 or 3 Black students in the whole freshman class. And I talked to one fella, he says, yeah, and half of those might not make it to the second year, et cetera, et cetera. But I think because of, and this goes back to, I guess, I use the word riots back in the 60s and 70s, the Kerner Commission, which you might have read about. I think there were a lot of changes. The goal was to make some changes in secondary medication, and that spilled over probably to postgraduate medication, the numbers. So the numbers have increased. But yeah, there were some issues back in the day. Fortunately, wholesale, I didn't experience that much because of the environment I was in. But I think for the good, but we have to be careful. I'll just say this about medicine. The pipeline has been contracted, especially for African American males. The pipeline has been stagnant, and even going in an opposite direction, perhaps. I don't have the statistics in front of me, but the African American male, the matriculation into med school is an issue. And as you know, there are a lot of complexities: finance, preparation, pre-med preparation, et cetera, et cetera. So there's a lot of work to be done there. I know MedChi, we support an organization called YoungDocsDC.org. They take some students. It's a local organization, very good, and exposed to doctors. The goal is to get those students to matriculate into the medical field. But that has to be duplicated, triplicated, programs like that to tap these young minds, these young students, at an early age. We're talking about 4, 5, 6, 7. Very important. STEM programs, et cetera, et cetera.
I was looking at, in preparing for our interview, looking back over the history of medicine in America as well as in DC, and AMA actually did an intensive research back in 2014, and found that the number of African American males in medical school during the Carter administration was 3%. And in 2014, it had dropped to 2.2%. And that there was a greater need, particularly with African American men. And why that is important is because African American men, non-physicians, have less of a behavioral change when advised by other than African American physicians. That's the greatest impact of change, when they are counseled and engaged by a physician who happens to look like them. Fortunately, we've seen an increase in admission to medical school for African American women. So I think there's some good and some bad with that. But I'd also like to ask you, we know that diversity in business creates, when they're at the table, when it's a diverse table, it creates a better product. Why do you think diversity is important in the field of medicine, particularly in the district?
Well, all we have to do is just go back to the history. Things change. I'm not going to sit there and go back 60, 70, 80 years. We moved on. But as we see the nuances that we see politically, as we see what just happened here in the Capitol, those winds are still there. Okay, I'm not going to espouse upon that. There's some people, who want to turn the clock back. I'll just say that succinctly. And this is probably in all sectors. I mean, there's a culture. And it was obviously, if it were not for that mirror image, that isomer, if you may, going forward, of good people who are goodwill people, that's the only thing that can overturn this. But I should tell people that the winds on Pennsylvania Avenue 4 years ago, are blowing. And we see with the things that have transpired over the last 4 years, and sometimes this has a spillover, even in the medical field, et cetera, in terms of admissions. They keep talking about these lawsuits, who can go to med school. And, I've been discriminated against because he got in and my MCAT was a little better than his, that type of thing. And I think that's very important, okay? And we have to look at the disparities that have taken place for the last hundreds of years. It's still going on, economic and social disparity. If my net worth is only 10% of yours, talking about typical African American, then maybe I couldn't buy the computer or that hardware that I need to get that information so I could do well on the exam, whether it's a standard exam or admissions test for something. So I remember looking at a show years ago, and I think the fellow, what's his name? He's back in the house now, I think. Kwame Fuse out of Baltimore. And it was he was the moderator of the show. And I remember this case because it kind of, what the gentleman said, the lawyer said, the African American lawyer said, gee, it was so on point. There was a Caucasian gentleman, and I think it was in Colorado, and there was a contract that was given to the African American company. And even though there were some elements that the company might not have been as proficient as the Caucasian company, but the gentleman, the president of the company was there. He said, why are you blaming me for the sins of my father? Caucasian gentleman. But I remember the lawyer recanted. He says, you have been the benefactor of the sins of your father. So when you put that in context, this is not new. We're talking about, wealth, we're talking about head starts, et cetera, et cetera. So it is important, wealth in terms of, I'm going back to post-war, when the GI loans were given out. There's some issues with that. Folks could buy houses, GIs. And of course, your house, your home equity, your net worth was predicated a lot ultimately on home equity. Gives you some leverage to do other things. So African Americans were kept out of that. So it's not one succinct thing, but it's very important. But succinctly, young African American males, they need to and communicate with people that look like me, who will say, oh, you're a physician, tell me how to do this. So this is important. So we need to, African Americans need to basically, triplicate, duplicate, our efforts to do more engagement with these young, middle school students at an early age, get involved with school. I used to go back to my son's schools to do career day, and I talk about medicine. We have a list of things, and the students, some of them got very excited because they just didn't see that. So this has to be, done much more. It's being done, but we have to make an effort, African Americans, especially physicians, to really go out and try to clone ourselves, to engage with this youth, next generation and subsequent generations coming forward.
On that, to extend that, what would you tell, three-part or three segments in this course, what would you tell a medical student about, what advice would you give a medical student in practicing medicine and who's maybe considering staying in DC to practice medicine? In the same part, someone who's a resident who is deciding or making career choices of where to practice within the district, what would be your advice to those two segments? And I'll hold off on the last, the one who's leaving residency and have decided to stay. We can get into that, but I'm particularly interested in understanding what would you tell the medical student and the resident, different from the resident.
Well, the medical student, I guess, the big piece there is post-grad training. That's probably perhaps going to be on their mind. And of course, here in DC itself, you've got your med schools, Howard, Georgetown, GW, and I guess, in Baltimore, U of M and Hopkins. So I think in terms of staying in the area for postgraduate training, You were talking about residents in a minute, but the demographics of the city, as you were aware, even if you've only been here, I've been here since, of course, I came freshman, since '66. And the demographics have changed immensely. And I remember when I came, I can't remember the census, but just a couple of years ago, it was only like 550,000. I think we're up to about 700,000. So we got to look at property value, cost of practicing in DC, what patient population are you going to see? And I have to invoke the word gentrification, which that is huge. Because, I remember, like I said, being here prior to the riots, prior in the 60s, where, the population was immense, African Americans. Of course, that has contracted. And what has happened through the years, some of the district's population, if they didn't go to PG County, or Montgomery County for that matter, a lot of folks, if they could, they went south. So I think what has to be taken into consideration are the demographics, because there are some issues that we're still grappling with that will, Caucasians come and see African American physicians, number one. And you're probably going to get a mixed answer on that. And folks will do their homework like in any position and study. But I think years ago, you had African Americans that wouldn't even see African American physicians. So I'm saying you got to bring that in, the cultural elements, racial elements. Where would you practice? Where would you open your office? The demographics. Can you be supported? So this is very important, because, and we're still changing. District is changing, every day in terms of those demographics, and the property values, are insane. I bought a house here. Well, it's my second house, but I sold the first one. But I bought a house. The house I'm in now was in '83, and if I was coming out of med school, I couldn't buy my house, or coming out of residency for that matter.
In the district, you live in the district.
Values the quintuple. The property value in the district. I mean, little shacks that post riots. I remember after the riots, '68, there was some old townhouses on Capitol Hill that was shells, if you may. They were there. I'm not saying they're destroyed by the riots, but that era, because folks moved out. And I remember a fellow said, "Hey, you can get two shells for $10,000, 2 for 10." I was just a student, didn't have money. But now, developers came in, whether it's Capitol Hill or Logan Circle, you're talking about multi-million-dollar properties now. So all of that you've got to tie in. Your population, who are you going to see? The cost of you opening your office, the cost of malpractice, which is another issue in DC. I remember the doc who delivered my sons, this is years ago too, he said I would have to deliver 35 babies a month just to stay afloat. He said, I'm getting too old for that now. And those obstetricians are paying, $120,000, $130,000, $140,000 a year. You'd have to be on an umbrella or part of an organization. So malpractice is another atrocity, if you may, here in the district, which quickly, I remember talking to one of my colleagues, she practices in Houston. She's an anesthesiologist, she has practice. And I was just asking a couple of years ago, she was with the alumni organization. I said, well, how's your malpractice? She said, $18,000. I said, whoa. So that's tort reform, which is something that it's almost like pulling teeth, because you get so many lawyers, and of course, whether it's local or in Congress. So that's a big issue for physicians. That's a long, tough nail. But that's an issue that something needs to ultimately be done. But it's, people talked about that for 20, 25 years to no avail. But I think to answer your question succinctly again, one is, what kind of practice are you having? Who are you seeing? And insurance. You probably have to have a motley of, folks, whether it's private insurance, a little Medicare, Medicaid, et cetera, but to survive. So all of this is important. And there are a lot of folks who actually are practicing on the fringes, in PG County, Montgomery County, which is a little more, it's a very diverse population, but you have a lot of African-American physicians who set up office out in places, like Laurel, Mitchellville, et cetera, But yeah, that requires a study, something that requires refinement. And then of course the excellence par excellence, I'm a believer of that. If you're good, people will come to see you. That's the old adage, which ultimately was one of our professors, Dr. LaSalle Fall, he passed about 2-3 years ago. But he would talk about that, excellence. So once people know you're good at what you do, and that could, change a few things. So that's I just want to mention that, not to use solely on ethnicity or anything reason, but those are the issues that we have to look at and continue to look
Well,
at.
I'll say this, and this will transition into the physician who is new to practice in DC. I'd say in 1990, I came to the district, like yourself, from New York City. Well, from New York, you were Yonkers, north of us, north of Bronx. And when I came in 1990, Howard and Georgetown would cross the Anacostia River and attend to patients at DC General. And so there was an exposure to that ward and to that population. Today, all medical schools are west of North Capitol. And their involvement as far as the population that they see is mostly west of North Capitol. So our young physicians aren't exposed to the needs through experience of that population. How has that changed, and what advice would you give a new physicians coming in, not understanding the needs and lack of resources in that area of the city?
Yeah, I'm glad you mentioned that too, because you were at DC General, so was I. And the early days in the 70s, I should say, mid 70s, late 70s, maybe early 80s. There were 3 schools there, as you mentioned, Georgetown, Howard. Third school was GW. Can't remember the year they pulled out. They pulled out and went to Fairfax. Oh. Yeah, GW used to be a DC General. So there were 3 services. You had Howard, GW, and Georgetown, and OB, internal medicine, surgery. So, and the patients were rotated. Most of them were in Southeast Washington, that came in the emergency room, et cetera, et cetera. So basically all facilities took turns, by and large. I remember I had a Georgetown attending and I was rotating to cardiology. But you're precisely the case. A little history on that. You probably were in town then. Former President of Howard, Swaggart, there was Mayor Williams was the mayor, and there was a deal to build a new hospital on the campus of DC General. And people were looking forward to that, a brand new hospital. But at the 11th hour, the deal went south. There's all speculation of why this could have happened. Could have been one of the councilmen that was politicizing the event and said, wait a minute, some of these patients should be going the west side of town, but they won't be coming over because of the hospital, et cetera, et cetera. I never know the truth of what had happened. Howard was supposed to put up 10 million, I think, and the city was going to put up 10 million, and then Howard was supposed to run the facility. But I think that's probably 12, 13 years ago. All for naught. At the 11th hour, that failed. United Medical Center, as you're aware of, the predecessor was Greater Southeast Community Hospital. Prior to that was Hayford's. So and that has a little history itself. That was one of the hospitals where folks rotated as well. Demographics of Southeast were different. When I came to Washington, there were quite a few Caucasians that lived in Southeast. But they say metropolitan areas change every 20 years, et cetera. But that has a lot to do with it, your exposure. Who are you going to see? And I remember this could have been rumor mill, but maybe not, because I've been seeing this even at Howard. You got a VIP patient coming in who's in ICU, CCU, and the attendant says, "Oh, don't worry about Professor Jones over here. I'll take care of him. He doesn't want the residents or the students to look after the patient for whatever reason." And then you'd hear some rumors way back in the day where if you're over Georgetown, and you're African American, you don't have to see her. She might not. Well, I experienced that in the Coast Guard. Not grotesque, but I was a branch chief, senior medical officer, worked hard, did treating patients, and on occasion somebody would come in and the nurse would tell me politely that because they had to get a comprehensive physical, including the gynecological piece and everything else. But when they saw the doctor, sometimes there was a change. So-and-so was having some physiological issues going on now. They're rescheduled that part of the appointment. But yeah, there's always been some subtleties. And I keep going back, gravitating, but when I came in the Corps, that first clinic I went to, the Switzer building, I have a Caucasian general. When he came in and saw me, he cringed almost, and it's like, wow, you're my doctor, as if to say. But fast forward here, I'll never forget, we established a relationship. And when I was leaving the clinic, he came back one day just to thank me for being his doctor. He says, I was reluctant at first, but you're one of the best doctors I've ever had. I want to thank you. Caucasian general lived out way up Virginia. But yeah, so, behavior can change, but, demographics, that's going to be a problem. I think going forward, tied into economics and perceptions, and a lot of perceptions that we have to deal with. And, this is an ongoing issue. The new doctor moving to town, sure, he or she obviously is going to have to get involved with local medical societies, MSDC, MedChi, et cetera, to establish those networks. And of course, the culture has changed. There are more physicians that, hey, I never thought that I would be doing, ambulatory care with the government. My goal was to have this big sprawling practice, prior to coming to med school. Something that didn't happen. But as you know, we're having more and more physicians who are employed now. And that has changed the culture to some degree. And I remember the old docs, 15, 20 years ago, they were irate at those people who were taking employment, as if to say, oh, you're selling out, blah, 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 blah. But yeah, there are a lot of dynamics here. And like, one is they have to network, they have to align themselves with medical societies because they're going to need, a referral basis to get patients if they're in private practice. And, and that's very important if they want to survive.
Have the resources, when you started practice here in the district, have the resources decreased in assisting physicians who would like to start practices in Ward 7 and 8? Are there resources available?
Well, I would have to never say, back in the day, I use that word back in the day, yesteryear, it was more tongue in cheek.
And today?
You're going to back then, you go into a meeting, MedChi, and perhaps MSDC at a time, I'm just saying, and you meet somebody, you meet 4 or 5 docs, and they say, oh yeah, give me a call. And you sit and it's almost like mentoring. You establish these relationships, this is what it's about. And the doc would say, oh, by the way, Dr. Jones is going to close his office in about 2 months. You might consider buying his practice. A lot of that has changed. I find there's a little more with the contemporary younger people. They seem to be a little more aloof. And I don't know if that's the right word.
How so?
Probably, I remember when I was, in residency or, early years when I was doing, I wanted to establish relationships with the docs who are out there, talk to them, pick their brains, basically, hey, I'm so-and-so. I'd like to chat with you for a while. And, there again, that varies too. I mean, there were some doctors probably, hey, I'm busy. But for the most part, they, hey, I'm going to open the door for you. I'm going to show you what you need to do. And things are probably more simplistic. I remember to get you, after you got your, to get Medicare and Medicaid, all you had to do is join the DC Medical Society. Okay. And then you got your Medicare and Medicaid. So things are a little more simplistic. And now, of course, things are more complex because there's so more, like I said, the malpractice, the computerization of medicine, the metrics that are involved, and all of it. And some of the old guys, I know years ago, when they take the survey, they'd say, hey, would you do medicine again? And back 10, 15 years ago, probably 50, 60% of them say, well, no. Of course, that's changed when they see other segments of the society change. Oh, they got problems too. So I think the ideal for old docs coming in was laissez-faire, okay, independence, very academic profession. You never stop learning, or growing. And a lot of that has change, electronic health records, metrics, CMS, all of that, the requirements. And it can be quite frustrating. And that's why the old guys, some of my age, who were closing their offices because of these metrics and these requirements. And also, I must admit, the technological things. I mean, you can learn, but if you grew up with a computer, it's a little different, when you didn't have a computer until 1990 or 1995. So this is going to require basically committee subcommittee study, ongoing kind of subcommittee action to inject variables that will occur from time to time. But it's going to see change in a sense. The art of medicine is great, but the business of medicine, it's a little problematic. And we need to reciprocate and engage more with each other. Like I said, the 30-year-old versus the 60 or 70-year-old. Okay. And that's where I'm going with that. And I think a lot of times the younger people, well, now we're in COVID, but, virtual. Sometimes we need to, here's an old euphemism, press the flesh. On occasion, see people, talk to them eye to eye. Boom. Establish a relationship, exchange cards. Boom. So that culture has, changed somewhat. And there are more constraints on, young physicians, of course, coming out with families. It's tough. So, but like I said, this is an ongoing issue, and that we're going to have to engage more frequently, across the spectrum, across the decades. And I think that would be my recommendation. Continuous interaction as much as possible, and whether it's caused by receptions, which we're guilty of. We talk about things, and I don't follow up. We're all working sometimes. We're all tired. The older you get a little more tired. The energy factor, those DNA bonds have changed. So, and that's why I'm hoping, people to fill these spots. Get some younger whippersnappers to come in and with, energy and wherewithal. Go ahead.
Well, I have a question with that. We see a shift in the industry, and that the business of medicine, and that most physicians some time ago were self-employed. They were the practices either solo or multi-specialty was basically run by physicians. They own the practice. And that created certain influence and change as well. Today, it has shifted. It's mostly organized medicine. I'm curious to know your thoughts on how has the practice of medicine, particularly for African-American physician, been with that change? We know they're less solo practice, but how overall, in general, as the successful career of an African-American physician today, as opposed in organized medicine versus not being in organized medicine?
Yeah, I'm gonna evoke something that really happened to one of my colleagues. She was an old obstetrician. This is said to be about 15 years ago, but husband is a physician. I won't mention names, but they were doing extremely well. He's an internist. He was OBGYN, and I remember all of a sudden, she said, "Ooh, what happened to my patients? They disappeared." So we're talking about, insurance. We're talking about, when the HMOs came out initially, and they had more restraints, more governors on where the patients could go. Oh, you can't see Dr. X anymore. You have to see Dr. Y over here. And, part due some of the agreements that maybe even physicians did. But I remember, and even I have another friend. He's not practicing now, but he was an anesthesiologist. He was doing a lot of electroconvulsive therapy work. He would be the anesthesiologist, outpatient treatment, et cetera, et cetera. But doing well, he had a lot of patients, and all of a sudden, his patients vaporized, a lot of them. So there goes his income. So the panels, the insurance, that's another facet. that has been a factor in the past as well. In other words, Mrs. Jones, who saw you for 20 years because in her insurance program, she can't see you anymore. I haven't looked at that recently, but that was, I remember that was the beginning of a deluge, an exodus, and that hurt. Matter of fact, this physician even left, obstetrics and gynecology at that time. Yeah, the patients, the wherewithal, who can see you, and with your patient, base. That's important. So that insurance factor is very important. And of course, as we know, physicians, in a sense, have been taking it on the chin, through, I would say, through the years in terms of, we can look at things like fee for service, or quality management and all that. I've always talked about for years, here I have, let's say I'm in an office in Southeast, and my reimbursement is going to be based on my quality of care. But here I have a lady, for whatever reason, historical, cultural, she's overweight, BMI, okay, A1Cs, blood pressure control, you name it. And somebody's doing the checkbox and say, well, Dr. Williams, you're not doing such a good job with Miss So-and-so, basically compliance with regimens, with diet, then the economics, what's going on in the household, versus maybe I have a patient who's eating alfalfa sprouts 3 times a week, and he's jogging and running and working out. Obviously, the endpoints would be different, but that's what I'm saying. This whole, compensation based on, it's kind of like gymnastics, the degree of difficulty. So that's one problem that African Americans have because of the culture, the economic disparities, the social disparities. You've got a different patient, by the most part. I'm not talking about the middle class, upper middle class African American, even they have issues, but basically I'm talking about the compliance issues for whatever reason. I had no money to get to my appointment, especially you say now. So, and yet you're going to be rated or reimbursed based on your performance, your metrics. Gee, your ladies, ANC is 7.5. What happened here? So, there are a lot of variables here that we have to talk about. And but I think the big thing was physicians back in the years ago were fairly independent. They had their own offices and they did what they want. And now you have a lot of physicians, of course, who are working for others. And then physicians used to admit their patients, in the hospital. But now you go to the door. Well, we have Dr. So-and-so who's a hospitalist. He'll be taking over the care of the patient. In some cases, fine. I mean, you've got a general practitioner versus somebody who's, boarded in, critical care, who's a hospitalist. Obviously, there's some issues there. But by and large, years ago, physicians would make rounds in hospitals, see their patients. They can't do that anymore for the most part because of the way the hospitals are. And then you had hospitals buying out practices. That went on 10, 15 years ago. So, here, I pay you this to go away so we can get your patients. It won't be, and it's still going on.
Do you think that movement has hurt?
This is a complex situation,
Okay.
Very complex.
Right. So lastly, what do you see for the future in African American, the practice as well as practicing in the district? Recognizing that there are needs in certain wards, but overall, what would be the practice of Black medicine, so to speak, in the District of Columbia?
And there I hate to keep going back to demographics and geographical location. And that's going to be important. I mean, we take a neighborhood, let's say like Shore. I remember a couple of years ago, I was talking to a pediatrician at Howard, and she would say some of the mothers would bring, these are the new residents in Shore, maybe with the young kids, they were coming for the, the immunization for the child. But for follow-up, they would go elsewhere. So, we've got some issues that we have to resolve there, but the future is going to be predicated on the things that we talked about. Just this issue with United Medical Center and GW. Of course, I forgot about Providence Hospital, which is closed. And that was huge. Right. So here we had a bastion of a hospital and you had African-American physicians, subspecialists, specialists, for probably 50 years. And all of a sudden, hospital gone, for the most part. United Medical Center, with this new arrangement with GW that the city has, it was $300 million contract. Initially, there was some certainly concern about, well, gee, Providence is closed, and GW will have sole source, or United Health Services, sole source, contractual relationships with this new hospital. And I think it was President Frederick at Howard and the dean, and of course, people like myself, concerned, well, what about, let's say Howard students, as opposed to the old days at DC General with Georgetown, and GW and Howard were there. And sometimes students rotate to different services, et cetera, et cetera. But here we are, the first thing that came, you got a med school, and the question is, where are your students going to be trained? And that was an issue. And then finally, as you may be aware, that apparently the mayor came up with some resolutions that because of tax abatement, how it might get this and that and the other, there will be a new hospital. In other words, we'll take care of Howard University, blah, blah, blah. It's legacy, 150-year existence, et cetera, the hospital, that type of thing. But that was the first question. Where are you going to train, in terms of students, where are you going to train your students and your residents? Because right now, Howard has, let's say, they have about 200 residents. Of course, there's been a memorandum of understanding, which I don't know no particulars about it, with Adventist. I don't know where that's going. So that's going to help. And I think the relationship with the city and Howard, and by, I think, 2025, 2026, there will be a new hospital for that. But we're talking about African-American population. Notwithstanding that, there again, the demographics will probably keep changing because of the escalation in property values. This is going to continue. So the question is, how do you attract a new patient base? That's probably going to be the question going forward. And what would you do to attract this patient base? And then again, will people come across town or across counties, if you may, whatever, jurisdictions to see you? And some of that is true. And the question is how much. If I can go around the corner and see Dr. X, but I got to drive, 10 miles, 15 miles. I mean, some people out on the hinterland, they drive 30, 40 miles. But anyway, those things are going to be important, convenience, because, back in the day, physicians and patients might sit in the office for a long time and they're missing work. And maybe if they're employed by others, the supervisor might say, hey, you've been going for 3 hours. What's going on here? Yeah. So like I said, it's not a simplistic thing, but the demographics, a lot will drive your answer.
Okay. Are you particularly
will you be able to see, and will they come and see you?
Right. So are you particularly concerned with, as I opened in saying that African-American men are reluctant, would have better behavioral changes when engaged by an African-American male physician? Are you concerned about that with this new relationship?
Oh, yeah, very much so. Yeah. You even see this with the COVID, SARS-2 vaccine. This whole statistic, the African Americans, even though they get 40% of the deaths in Hispanics, the reluctance to take a vaccine. Okay.
Is 80% of the population.
I got a young son who's 25, and their utterances of, don't take that vaccine. But this is the internet. This is that culture. And that's one thing that has hurt America to some degree. Social media. People go on there, they say anything and they hide. And then some of the young people, they get a lot of information off the internet. They think that's the gospel. So it's not proved like the old scientific methodologies that we had. They're not resorting to the bastions of science. Check NIH, check National Institute of Mental Health, check this, check, where'd you get this from? John Doe, here's a website, here's a webinar or something. And then you have the anti-vaxxers. So you like this conspiracy thing. We see this, QAnon and all this. So the culture has been, indelibly involved because of this social media. A lot of it's fallacious. They're getting facts. But I'm just saying that, you've got African Americans who need to be the first in line to take the vaccine. And they're saying, well, I'm not sure if I'm going to take it. Now, we know about historical stuff. Fine. But you're right. So if it's somebody like me and I'm talking every day to different people about this, yeah, I know you read, about Tuskegee and blah, blah, blah. But hey, this is a new time. We got a menace out here. We got you got a virus out here. You can't see this virus. You don't have an electron microscope. So, and then trying to convince them that the side effects from this virus is worse than the side effects from the vaccine. But seeing somebody that looks like me talking even about vaccination, talking to young students about medicine, the nuances, and maybe some of the obstacles that most people see, because we know the cost of medical education is tremendous. So this has to be dealt with. All of these ongoing.
Yep. I'll tell you, Dr. Williams, President of MedChi, who has been seeing patients in the District of Columbia since the early 1970s. I think your experience is very valuable. I think you've seen great changes. I can understand some of the concerns that you may have, particularly at the current situation with our COVID and the plight of the Black man and whether he would receive the vaccination or not due to the effects of false information or the history of the United States. I thank you for this interview. I appreciate that you take time out of your busy schedule to be with us to help our members hear some of the history, particularly our younger members of the medical society. And I hope this interview can be extended also to your members in MedChi. If they're not a member of MSDC, have them come over to our website and hear this interview.
Right, and that's going to be, one of my pushes. I want to get more. You have some members that are members, but I'd like to get more. And there again, this COVID thing has kind of slowed down the bucket list, of course, things to do, engaging with these young people, like the Student National Medical Association, no excuse for me. And this is the kind, we have to establish these relationships early. So even when they leave town, they go to another city with similar problems. So, but I want to thank you for your time and inviting me. And I'm here at all times, and I'll be much obliged to talk to my colleagues, a lot of them which would be obliged to come and speak to you.
Great, that would be good. We're here as well. The alignment and collaboration is well welcome. So I hope this continue in the future.
Okay, yes, and I certainly concur, and I want to thank both of you. Thanks so much.
Thank you very much, and enjoy the rest of your day.
You as well. Take care.